abstracts, housekeeping time. 12th Norman Bethune Symposium, April 18th. The abstracts for that are due on Friday. And I might remind you to, when you attend that diligently, stick around for the last seminar given in that symposium, because that would be me. So I will be watching for faces. CBR Research Day date has been set for August the 15th. And also, even later, set your calendars for November 13th, because the 17th Earl Davies Symposium. So please, I don't see anybody's phones coming out, so make sure that that date is in there. And it is my pleasure to introduce Pascal Bernatchez. That's you. He did his master's and PhD at Université de Montréal in pharmacology. He started there in vascular biology and continued at a postdoc in a very distinguished laboratory at Yale. He is now associate professor in anesthesiology, pharmacology, and therapeutics, UBC, and his laboratory is at the Heart and Lung Institute at St. Paul's. And I'm thrilled that you're able to join us today. Thank you very much, Pascal.
My pleasure. Thank you very much. For your time. It's a pleasure for me to be here and talk to you about some of the various projects we've been involved in the lab. So before we get started, just a little bit of housekeeping. Good news is that I tried to make the talk like accessible, and because some of the things we're working on are extremely complex, you'll see why later. But I tried like to stay to a certain extent at the surface of things, just try to make it more accessible and like to stick with topics and fields that everyone can relate to. That's on the good news. The bad news is that I'm a consultant for a foundation and a company, so just keep everything I say with a grain of salt. I co-founded AR Biotherapeutics on campus, and also probably the most important warning of all is the last one, animal experiments versus patients. Some of the movies I'm going to show you, some of the pictures I'm going to show you might be disturbing for some. If you're used to animal research, you should be fine. But keep this in mind, if what our animals are subjected to is identical to what our patients are subjected to. But again, if you're used to animal research, you should be fine. Feel free to interrupt me if you have any questions during the talk or after. All right, so without further ado, we're going to cover a lot of grounds today. So this is the vasculature, 40,000 kilometers of vasculature in our body, just like as a point of reference, that's more than twice the circumference of the Earth. There's a lot of blood vessels in our body. Every tissue is perfused. And for an endothelial biologist and endothelial pharmacologist, such as myself, this is really interesting because there's a lot of endothelial cells in our body. I mean, 40,000 kilometers of endothelial cells. And from a signaling perspective, it also means that there is a lot of blood flow, a lot of shearing of those endothelial cells. And you'll see we're going to cover this. I'm assuming you can see. No, you cannot see my pointer. Just give me a second. Later. There we go. All right. So yeah. So there's a lot of shearing of endothelial cells, and it's a topic that we're gonna discuss more than once in my presentation. We're going to talk about caveolae, which are those membrane organelles at the luminal side of endothelial cells. They're part of the mechanotransduction, mechanosensing machinery. They sense flow. And we're going to talk about protective flow, mechanosensing, but also like proteomics of those caveolae lipid rafts, which are also summarized as cholesterol-rich membrane microdomains. You wouldn't believe what we found in those endothelial cell cholesterol-rich membrane microdomains. But the real reason why we're working on endothelial cells and the protective flow and mechanosensing is most vascular events tend to occur in areas of the vasculature that are affected by turbulent flow, which we can see here on bottom right. So those turbulent flow events, for various reasons, tend to increase the incidence or prevalence of atherosclerosis, even thrombosis around valves, for instance. And that's because the endothelium has the unique ability to sense flow. How it senses it is, varies with the location. So there's laminar flow that tends to be very protective. Think aerobic exercise, like increasing blood flow, shearing of the endothelium, that's good. But turbulent flow around those bifurcations, for instance, that's bad. But if you think about it for a second, this is just signaling. Here, the endothelium senses something, whereas here it senses something different. It's called mechanosensing or mechanotransduction, and this is integrated in the cytoplasm differently. But one thing we're interested in is to reprogram the endothelium into thinking, for instance, if it's in a turbulent area, into thinking that it is located in a laminar flow or protected region. So one of the key questions that is relevant to this presentation, for instance, is can athero or thromboprone areas of the vasculature be reprogrammed into athero or thromboprotected sections? Again, it's just signaling. It's just how the endothelium senses flow. And when it comes to endothelium and flow, yes, I mentioned earlier caveolae, which are those membrane invaginations on the luminal side of the endothelium. They're part of the shear stress or mechanotransduction response machinery. The main protein is caveolin 1. And caveolin 1 is the main negative regulator of eNOS, the endothelial nitric oxide synthase. And eNOS releases NO. If you've heard of Viagra, you've heard about NO. But this is with NO with prostacyclin and EDHF. These factors are called endothelial function. And there's this condition, especially in twisty sections of arteries that are affected by endothelial dysfunction, which is basically low NO, low PGI2, low EDHF, or endothelium-derived hyperpolarizing factor. So basically, the protective properties of the endothelium are downregulated in part because of this turbulent flow thing that I mentioned to you earlier. So we're interested in this. But also, I'm a pharmacologist. We're interested in stimulating the endothelium, again, in thinking that it is in those atheroprotected sections of the vasculature, but also to try to stimulate the endothelium into over-expressing, over-releasing those protective mediators of endothelial function. And one of the key ways to trigger this unique type of signaling, again, it's all signaling, laminar flow, turbulent flow, it's all signaling for the endothelium, is to basically try to better understand and modulate this interaction between eNOS and caveolin 1. So it's a direct protein-protein interaction. Caveolin 1 is a negative regulator of eNOS. It's an inhibitor. And I'll give you the download right away, is that we're trying to develop eNOS caveolin 1 inhibitors. And you'll see this project took a really, really unique turn of events a bit later. So we're trying basically to inhibit the inhibitor. We've designed this peptide a while back. We're going to get back to this a little bit later, but this peptide is called cavnoxin. We basically characterize how eNOS and caveolin 1 are bound together, are interacting together, and how caveolin 1 inhibits eNOS. And basically, this peptide, we've published this, inhibits contractility on for instance, on a wire myograph by around 80%. So you increase phenylephrine concentrations, you increase the contractility of control vessels. But vessels treated with this cavnoxin peptide, it's an inhibitor of the inhibitor. It blocks the negative effect of caveolin 1 on eNOS. There's no effect in eNOS knockout, so we know we have a very specific NO targeting agent. It inhibits contractility by around 80%. We've published this in all mice, but what I've never published, and I've been sitting on this data for more than 15 years, is the fact that mice, young mice, do not respond at all to the exact same peptide. For pharmacologists like me, this is really interesting, because if you have a age-specific target, you might develop age-specific drugs. That's really, really interesting, at least to me. So this peptide called cavnoxin, we tried it in different settings. We published this study in 2015 in diabetes, where we look at atherosclerosis in a typical ApoE knockout model of atherosclerosis, and also diabetes accelerated models of atherosclerosis. You can see the atherosclerosis in red is inhibited by around 80–85% with those cavnoxin injections. This is a 2-month-old study. But what was really interesting is that when we did the ApoE-enos double knockout mouse to show that the effect is specific towards enos, well, those double knockout mouse, first they show more atherosclerosis. It shows how protective NO, enos, and the shear stress machinery of endothelial function is protective. So there's just more atherosclerosis, but they're completely resistant to the effect of cavenoxin, knowing that we're targeting this system for real. So yes, that part is published, but exactly what's going on when it comes to aging and the vasculature, this is unpublished. And in fact, we're working on this with Robert Nabi and one of our former students, John Lim. Big shout out to both of them. They've been really good collaborators. But again, this is data from, I've been sitting on this data for 15 years. This is unpublished. You can see enos, or the endothelial nitric oxide synthase. It's the source of NO. Again, think Viagra. This is what Viagra does. It mimics like a hyperstimulation of enos in the vasculature. You can see here enos is concentrated typically around the Golgi. Enos is a Golgi-loving enzyme. These are not cell culture system. These are whole mount arteries, ex vivo preparations basically. So there's no culture artifacts. This is ex vivo. But if you look at enos in old arteries, you can see here that enos is completely, the localization of enos is completely different. We're not sure exactly what it means. I'll give you my hypothesis a bit later. But if you look here, this is epifluorescence microscopy. This is confocal microscopy. And you can see here that enos is typically present in the Golgi. We use GM130 as a marker. But in old vessels, when we look at 12-month-old or above the vasculature from mice, there's a lot less enos. Enos is mostly targeted to the Golgi, but the Golgi apparatus is much, much smaller in old vessels than in young vessels. And yes, there's also an increase in caveolin 1, which we're not sure exactly what to make of. But here, there's something that we're interested more and more. It's the topic of Golgi fragmentation. It's not a common topic, but this topic of Golgi fragmentation in neurodegenerative disease is known, but in the vasculature, we don't know anything about Golgi fragmentation in the vasculature. And we think that probably the Golgi fragments, enos is mislocalized, and that would explain why this cavenoxin peptide works really well in old vessels, but not at all in young vessels. But this is still a work in progress. So how do we translate these findings to the clinic? Well, like I told you earlier, we tried to develop a enos caveolin 1 antagonist, or a blocker of the blocker. We're trying to block this interaction between enos and caveolin 1. We basically made caveolin 1, the scaffolding domain is a 20 amino acid sequence. We tried to minimize it to like the smallest peptide sequence as possible. We went down to 7 amino acid, if I recall correctly. This is the one amino acid that inhibits enos, phenylalanine 92 or F92. It goes really deep into the enos pocket. It inhibits its activity. And we basically tried to use this template as a lead molecule, but to basically develop small molecules that can prevent the blocking of enos by caveolin 1. And when we started like getting like computer models involved in doing this particular project, someone came up to us and say, that sequence that you think is important, it's a bit long. I mean, usually for small molecules, you want 4 to 5 amino acids. That's the golden rule. But someone said that this sequence that you're interested in is really reminiscent of this class of molecule called angiotensin receptor blockers, or ARBs. So ARBs are anti-hypertensive, like the first FDA-approved ARB is losartan. They block, well, I'm sure you've heard of angiotensin 2. That's the #1 bad guy of blood pressure, or high blood pressure, or hypertension. So losartan and ARBs, or angiotensin receptor blockers, they block AT1, and they have like a range of beneficial effects, including blood pressure lowering. They're basically wonder drugs. You'll see why later. These are actually more and more popular than, for instance, ACE inhibitors. There are angiotensin converting enzyme inhibitors that prevent angiotensin 1 conversion into Ang2. And because this sequence, the molecular structure of losartan was of interest to some people in the lab who were interested in endothelial function, when we started treating our mice with losartan for a month, we basically observed like a very obvious, very like easily reproducible decrease in contractility when those mice were treated with losartan. And when we treat our mice with L-NAME or the nitric oxide synthase inhibitor, all this effect is completely gone. So I'll show you more data about this later. And I've been working on NO for almost 20 years. For me, it was really surprising to see this. Increasing NO, endothelial function in vivo in animals, especially in patients, is really, really tricky. So seeing this like 70, 60% decrease in contractility, I said, whoa, something's going on here. And we started looking at the effect of losartan on endothelial function. And this basically caught the attention of a group of investigators who study like aortopathies, which are diseases of the aorta. So when it comes to genetic aortopathies, the most common model of the most common cause of aortopathy is actually Marfan syndrome, which is caused by fibrillin-1 mutations. It causes like a range of symptoms and manifestations, but also the most serious one is aortic root widening or aortic root disease. These patients have kyphoscoliosis, but the aortic root is subject to like continuous widening. It doesn't cause aneurysm. It causes what we call a dissection, which is like a separation, a tear into the aorta. And if you have an aortic dissection, if you don't get emergency surgery, you're going to be dead in a couple of hours. There's a mouse model. There's a couple of mouse models of fibrillin-1 deficiency. You can see here the aortic root, the wild-type mouse. This is the fibrillin-1 deficient F92, C1039G model of Marfan syndrome. The aortic root is widened. The ascending aorta gets gigantic. There is elastic fiber fragmentation. Media gets thicker and thicker. And from a pathogenic perspective, it is believed that it is due to an increase in TGF-beta signaling. So fibrillin-1 traps TGF-beta, keeps it inactive, and when there's fibrillin-1 mutations or deficiencies, TGF-beta goes up. But again, the link between TGF-beta and medial thickening and aortic widening is not fully understood. So when we started working with the Marfan research group, a common topic of discussion was how losartan, which is the ARB that we found by mathematical modeling to be very similar to the caveolin-1 structure, how it works really well in mouse models of Marfan syndrome, but how terrible it works in patients. So yes, losartan works really well to prevent aortic root disease in mice, but in patients, so those patients are treated with two medications, atelanol, which is a beta blocker, or losartan, which is the ARB I mentioned earlier. And basically, when it comes to outcomes, we're not going to say it doesn't work, but at best, it just postponed the inevitable, which is aortic root replacement surgery. So this was like a big trial like 7 or 8 years ago, and it was really controversial. People think that those blood pressure lowering medications, atelanol and losartan, just doesn't work. And the hype around losartan from the animal model did not materialize. It's just as good or just as bad as atelanol. So what we did actually, what really sent the lab into a new direction was the fact that we developed Marfan mice that don't have the main angiotensin receptor, the ATR1 alpha knockout model of angiotensin 2 signaling downregulation. These mice were hypotensive, but they developed the same kyphoscoliosis, which was expected. But when we look at the media or the aortic root of those mice that lack the main receptor of the bad guy, they're hypotensive. They don't have the main receptor for angiotensin 2, but they develop the pathology just the same. They basically undergo medial thickening and aortic widening in a kind of an unabated fashion. And what was really disturbing to pharmacologists in the lab is that the response to losartan that we typically see in Marfan mice was also observed in Marfan mice that do not have the receptor of the drug. The drug is active without the receptor of the drug. So clearly that means there's some monkey business going on. There's something else going on with those medications. And we started thinking there were some papers out there that losartan is linked to a nitric oxide release, but never in chronic disease models. We did the same experiments that I showed you earlier. We treat mice for a month with not only losartan, but we basically look at all the ARBs out there. There's like 7 or 8 ARBs that are clinically approved. And we basically use what we call an EC5 dose. This is like the minimum dose or the maximum dose before we get like a obvious decrease in blood pressure. So we're basically trying to aim for no effect on blood pressure. But when we look at contractility on a myograph after 1 month, telmisartan increases nitric oxide release and prevents constriction. Again, I've rarely seen anything in vivo that increases NO release like this. This is a sub-blood pressure lowering dose. And if you block NO with L-name, this effect is completely gone at a sub-blood pressure lowering dose. So for us, clearly there's something going on with nitric oxide and ARBs. And when we started to treat our Marfan mice, not with losartan, with telmisartan, boy, is that thing active when it comes to blocking medial thickening. So typically in animal models of Marfan syndrome, losartan is used at the 300 times the dose used in patients. With telmisartan, we use twice the dose. It's the same ballpark, basically. And it's far more effective than losartan. So you can see here medial thickening, wild type, Marfan, obvious pathology. Marfan with telmisartan would completely block the disease. And again, we use 150 times less telmisartan than losartan. And if you block NO with L-name, all this gets reversed. You can see here again, aortic root diameter, vehicle, Marfan, telmisartan, Marfan. So we basically bring it down to control levels. We completely wipe out the disease with telmisartan. And boy, is NO active in those mice. These are wild type mice. This is a Marfan mouse. It's contractility. And then if they're treated with telmisartan, boom, way down. Contractility is almost blunted. These vessels look almost dead. They don't constrict. And when we put L-name in the organ chamber, they start constricting again. Clearly, those ARBs, those blood pressure lowering medication, do other things. They're massive NO inducers. And again, how this works, we're not sure. But one thing is also interesting is that we started using that minimal blood pressure lowering dose of telmisartan in those mice. They completely block the disease. We don't even detect a significant effect on blood pressure. They wipe out the disease. We can see here vehicle, Marfan with high dose telmisartan. We bring this down to basal level. And same thing for a low dose, a sub blood pressure lowering dose of telmisartan. There's just no more disease. So you'll see it gets even more interesting a bit later. So what we concluded from these studies is that in contrast to losartan, telmisartan can fully inhibit Marfan-associated aortic widening, at least in animal models, despite very similar blood pressure lowering effects. We don't think these are blood pressure diseases. We use it at 2x the patient dose. Losartan is used at 300 times the patient dose. Everything is blocked with NO, so it's an NO dependent system. Even at sub blood pressure lowering doses, and telmisartan blocks everything. And then basically, is it possible that NO, rather than blood pressure lowering, is behind their anti-aortic root modeling effect, especially in animals, because we use a higher dose, whereas in patients, losartan is used at a much lower dose, and there's simply not enough endothelial function activation, basically, with losartan. And clearly, this is not the problem with telmisartan. And is this why antihypertensive don't work in Marfan patients? It's not a blood pressure disease. You need something that stimulates NO, that stimulates endothelial function. So now we basically got funding from GADA, the Genetic Aortic Disorders Association of Canada, to study losartan versus telmisartan retroactively and prospectively in Marfan patients, pediatric and adult, at St. Paul's and Children's Hospital. And now basically we're trying to switch patient management towards NO activating drugs such as telmisartan, for instance. How do we get this closer to the clinic? Again, we're saying this is not a blood pressure lowering or blood pressure disease. What we did is that we treated our mice, wild-type mice or ENOS knockout mice, with either vehicle or telmisartan, and we sent tissues and blood samples for proteomics analysis. We found two ENOS-specific biomarkers of telmisartan. So basically, these are NO-responsive biomarkers of telmisartan activity. We tried to patent them. This is like an ongoing pet project. But from a tissue proteomics perspective, for some, and again, this is new. Nobody really understands this. Endothelial function seems to bulk up the aorta in terms of collagen and contractile machinery. There's more actin, there's more myosin. Everything that causes a vessel to constrict more is upregulated in an NO-specific fashion with telmisartan. Now, this is sweet. Things get even more interesting. I've never showed this data before. We made a Marfan-Enos knockout mouse. These mice, which we know should not be protected against Marfan syndrome, to develop massive aortic widening, which becomes lethal a little later. And basically, this could explain why Marfan patients have endothelial dysfunction. What I'm trying to say here, and that's been published by other people before, what I'm trying to say is that Marfan-associated arthropathies are endotheliopathies. They are diseases of the endothelium. That's how you sabotage an aorta. You sabotage endothelial function, and then the aorta will get bigger with aneurysms or dissection, in this case, of a Marfan-associated aortic root disease. These are not media or adventitia diseases. They are diseases of the endothelium. More importantly for pharmacologists amongst us is that those Marfan-Enos knockout mice, telmisartan lowers blood pressure, but it does not inhibit the aortic root widening. This is a pristine example of drug pleiotropism. Telmisartan inhibits aortic root widening not by lowering blood pressure, by increasing endothelial NO and endothelial function. And basically, this explains again why blood pressure lowering therapy in those patients is bound to fail. It's not a blood pressure disease. Kind of makes sense, right? And now we're trying to push the clinic to focus on NO, first with telmisartan and then with those biomarkers of NO-specific telmisartan response. Now, this is really interesting. The Marfan-Enos mouse that I just showed you, I mean, this really showed that we're onto something big here. What's even more interesting is that when we take an old mouse, an old Marfan mouse with a big lesion, if we give it telmisartan, we can actually shrink the lesion, which is the holy grail for patients. If you have a widened aortic root, we can shrink it with telmisartan. And if you use an Enos knockout, a Marfan-Enos knockout mouse, these mice do not shrink their aorta. There's no response to telmisartan. So this is, for instance, after a couple of weeks, this is the normal aortic root growth. If you give those late mice telmisartan, you shrink the aorta, and everything is blunted if there's no Enos being present. So this suggests that clearly Enos-derived NO not only has an anti-aortic root widening effect, but it can also regress established lesions. It really shows how protective endothelial function is. There's also talk about, there are talks about supratherapeutic doses of ARBs. Some people think that they have effects past their blood pressure lowering maximum dose. Maybe it's through NO, we're not sure, but clearly these drugs are incredibly pleiotropic. When it comes to their mechanism of action, we'll get back to this a little later, but you need caveolin 1 for these ARBs to be active on NO. We think they activate mechanosensing at the an Enos-derived NO, just like aerobic exercise though, that shearing of endothelial cells that causes like chronic hyperactivation of endothelial function. Well, this is what we get with those ARBs. Everything is done with a caveolin, in a caveolin or caveolae dependent fashion. And is this why ARBs are so good? If you look at in systemic hypertension in the province, diuretics, which are the go-to drugs for systemic hypertension, prescription keeps going down, ARBs keep going up. Why? They're pleiotropic. They do other things, and maybe in fact they mimic what exercise does to the vasculature. When our Marfan patients see our data, they say, well, for their kids, I want to be on telmisartan. Why? Because there's just so much more anti-aortic remodeling effects of those NO-activating drugs compared to the gold standard losartan or Tylenol. And this is a new topic that, or a new lingo that we've been using in the lab. We have, if the animal data is true in patients, maybe we have a massive unused protective endothelial function reserve. If you look at the data, I would say we use about 20% of our endothelial function. 80% is unused. If you have the right drug, right approach, we can crank this up and even regress aortic lesions. This is really, really important for to prevent vascular disease. We've always been interested in what goes on in these subendothelial tissues, but what also happens to the lumen, leukocyte inflammation, like leukocyte rolling, thrombosis, platelets sticking to the vasculature. What exactly goes on there, we're not sure, but that's something that really interests us. When it comes to telmisartan and therapeutic drug pleiotropism, things in the lab took a very unusual spin when we started treating our vessels with telmisartan for 30 minutes. 30 minutes, this is acute stimulation. This is ex vivo. 30-minute stimulation of telmisartan, boom, you basically prevent contractility. I would say 60% NO dependent, 40% EDHF dependent. And basically, the problem is that there's no Ang2 in those preparations. How can a blocker have any effect if the agonist is not there? A blocker should have no effect if there's no Ang2. Well, they're massively active within 30 minutes, even if the agonist Ang2 is not present. And then it became more and more obvious that those ARBs, like losartan and telmisartan, are studied in other conditions. And this is, for instance, it was published from Johns Hopkins, where they basically study losartan to prevent COPD, chronic obstructive pulmonary disease. It was really sad, actually. Their primary endpoint, they missed their primary endpoint at 0.06. They were really close to significance. What they're trying to do is basically prevent the progression of COPD with losartan, but these are not blood pressure related diseases. So for us, pharmacologists, that says that's enough, there's something else going on with those drugs. So what we did is we created with Marco Ciuffilini in chemistry, we created a new UBC Research Excellence Cluster called ATHEN, the Advanced Angiotensin Therapeutics Network, ATHEN. It's basically 3 faculty, medicine, science, and social health and social development, 12 PIs. Together, we have $8 million of funding on ARBs. And the cool thing is that these are all PIs that study ARBs, or telmisartan or losartan, but not in hypertension, in non-hypertensive settings. Like, for instance, COPD, chronic obstructive pulmonary disease, COVID-19, asthma, cancer, diabetes, Alzheimer's. And what we do basically, it's like a drug development incubator, like a startup network where we help with MyTax applications, for instance. We created the startup AR Bio, as you can tell, AR Bio, ARB, angiotensin receptor blockers. That's a little acronym. But what we're trying to do is basically develop new ARBs, ARBs 2.0, where we're going to have the same blood pressure lowering effect, but more of the magic stuff, more NO, more pleiotropism, because clearly they do other things. And what we were really interested right away, right off the bat, is to develop non-AT1 blocking ARB analogs. So we've modified the molecules, those ARBs, trying to get rid of their blocking, angiotensin 2 blocking effects, but keep the NO, the endothelial function enhancing effects of those molecules. We did this with Marco Ciuffilini. He's on campus most of the time. Easiest guy to work with. If you have any interest in chemistry, drop him a line. But what we basically did is we studied losartan and a couple of analogs of losartan. Losartan is a prodrug. It needs to be metabolized before being active. So losartan is an alcohol. It gets metabolized into a carboxaldehyde, and then it gets, again, metabolized into a carboxylic acid. And we noticed that only this analog, this metabolite, the EXP3179, is capable of activating NO. This is why losartan doesn't work well in Marfan patients. Only one metabolite activates NO, the rest does not. So it's a prodrug. Don't use this prodrug in patients. Just use a final drug, basically a drug that doesn't need to get metabolized. Just focus on telmisartan. Talking about telmisartan, those chemists are another level when it comes to chemical structure. They remember it by heart right away. He can draw this with his eyes closed. And what he sees is basically like, oh, change this to another molecule, another moiety. And we basically synthesize a bunch of ARB analogs. And we basically got 2 ARB-like molecules that no longer block AT1, but that still are capable of increasing in Orleans. These new molecules clearly show how pleiotropic those drugs are and how important it is to focus on NO in the vasculature. Does that make sense? All right, so now I'm going to switch gears and talk about the endothelium in neuromuscular diseases. Nothing to do with endothelial function, but I showed this before, the vasculature, the endothelium, shearing, caveolae. What we did a while back is that we isolated caveolae in lipid grafts, and we did proteomics analysis from those like cholesterol-rich membrane microdomains. And some of the most highly enriched protein in those caveolae lipid grafts are actually related to muscular dystrophy. This is this protein right here, dysferlin. Dysferlin. So basically, these are all proteins related to muscular dystrophy. This is the dystrophin-associated glycoprotein complex. If you mutate those proteins, you can have muscular dystrophy. If you see a kid in a wheelchair, chances are that kid has muscular dystrophy. And because we found them in the vasculature or the endothelium, we started thinking that there might be a link between the vasculature and muscular dystrophy. So this is, for instance, dysferlin. It's a gene, candidate gene for a limb girdle muscular dystrophy type 2B. You can see here, these are ex vivo artery. You can see plenty of dysferlin in green, like between the endothelial cells, for instance. We published this a little while back. And we said, yeah, there might be a link between the vasculature and muscle homeostasis and muscular dystrophy. And well, some people have been there before us. So this is the first paper that basically shows vascular endothelial cell injury and platelet embolism in Duchenne muscular dystrophy, or DMD, at the preclinical stage. Patients, even before they get diagnosed with muscular dystrophy, these kids tend to be diagnosed around 4 or 5 years of age, they already have like vascular complications. So basically in those preclinical samples, 20–40% of capillaries contain swollen endothelial cells, platelet embolism, for instance. And this gave rise to the theory that there's a strong vascular component that causes muscular dystrophy. It's called the vascular hypothesis in muscular dystrophy. But as you can see here in this title, another blow to the vascular hypothesis in muscular dystrophy. Nobody believes that the vasculature plays a role in muscular dystrophy. But still, you know, we kept doing our own thing. And we basically found plenty of dysferlin in those atherosclerotic plaques. This is an ApoE knockout plaque, for instance. You can see plenty of dysferlin plaque in the endothelium. We also picked it up in human, occluded human coronary arteries in the endothelium. You can see plenty of dysferlin. Again, these are muscular dystrophy related protein in the vasculature. What is it doing there? And because we didn't know what we were doing back in those days, we decided to grab the bull by the horn. We did like the double disease knockout, basically. So dysferlin deficient mice have a very mild phenotype. You would not be able to pick them from a lineup there. It's like, that's one of the main issues with mouse models of muscular dystrophy. They're mild. It's a ubiquitously mild. These are ubiquitously mild models of muscular dystrophy. They have no phenotype. And what we did, we took the dysferlin knockout mouse from Kevin Campbell. He was here actually 10, 12 years ago. And we basically made the double knockout. This is the ApoE knockout mouse. We gave them a high-fat diet. It's a typical model of atherosclerosis. I mentioned this before. And we just let the mice age. And then almost a year later, we got this one phone call from our animal facility that really changed everything we do in the lab when it comes to dysferlin deficiency. It was a call from the animal facility. I got the call, not people in my lab as usual. I got the call. And they said, Pascal, one of your mice got a stroke. A stroke. And I said, oh, I don't want to work on stroke. We don't have stroke models. And I'm not interested in stroke. So after a couple of seconds, I thought about it. I said, how do you know it's a stroke? Oh, it's easy. The mouse stopped walking. Okay. What's written on the cage card? Oh, it says dysferlin ApoE DKO, double knockout. This is the movie of the first dysferlin ApoE DKO, the double knockout. And keep in mind that mouse models of muscular dystrophy are ubiquitously mild. They don't have a phenotype. Our mice stop walking. We have the most severe mouse models of muscular dystrophy at St. Paul's. And we didn't know what to do. I'm not a muscle person. Nobody studies a muscle at St. Paul's. We basically dissect the muscle. This is what a typical dysferlin, very mild dysferlin knockout mouse looks like at 11 months. This is the double knockout at 11 months. There's just no more muscle left. So with Fabio Rossi on campus, we developed like histology, developed like how to look at those muscles. This is a dysferlin knockout mouse, like a bit of fibrosis in blue, but the double knockout, it's just like there's just no more muscle left. And we finally recapitulated the human disease, a human condition, LGMD2B or limb girdle muscular dystrophy type 2B. The muscle is replaced with fat. Well, now finally with our double knockout, we have muscle that's replaced with fat instead of having those really mild phenotypes, which is typical of mouse models of muscular dystrophy. So we expanded the colony, we reproduced the data, other people have reproduced our data. So clearly there's something else going on with muscular dystrophy and cholesterol metabolism. And I mean, that was 11 months, quite pricey to keep mice for this long. We basically speed things up by increasing cholesterol content of the diet. So we went from 0.2% cholesterol fat to 2% cholesterol chow. And these mice like nosedive far more quickly. Now they're pretty much only to be euthanized within 5 months of age. And you can see, you can see these mice, they really tend to fall off a cliff very quickly. Just give me a second here. They're humanized models of muscular dystrophy. It was incorrect. Basically, you know, like a patient has a stroke, you know, like they slur their words, they collapse. They thought that no, it was a stroke. No, that's not a stroke. That is humanized models of muscular dystrophy. Beg your pardon?
Why did it take so long without the water?
Because, well, now it's 5 months, which is not that long. We're talking about like 3 months on a high-fat diet, 2 plus 3. Or high cholesterol diet. Well, I mean, muscles have a massive ability to regenerate. Massive. If you mess up cholesterol homeostasis, something else is bound to happen. But look at this. This is what's going on now in mouse models of muscular dystrophy. So, so we reproduce. Yeah. Sorry, what? Yeah. Correct. This is a very good question. So mice are nocturnal. They tend to be active at night. And it seems like the pathology tends to get worse at night and in the morning. And then because they rest during the day, they get better during the day. So you have to look at them earlier in the morning. And then this is when you realize, no, this mouse needs to be euthanized within 24 hours. Because it cannot feed themselves. I mean, this is like our human endpoint. We cannot keep them. Once you really see ambulation dysfunction like this, we have 24 hours, which is totally fair. So yeah, so basically these mice are very, very symptomatic, and again, we expand the colony. Now we're kind of lucky. We only keep them for a couple of months, 3 months on a high cholesterol diet, and then the disease severity is massive. Everything that I showed you so far is basically comes from LGMD2B mice, which is this type of muscular dystrophy here. But the big kahuna is DMD, Duchenne muscular dystrophy. Because it's lethal, it's far more common than LGMD. So we basically took an even milder model of muscular dystrophy. We took the MDX mouse model of muscular dystrophy, and we basically made the double transgenic, basically. And boy, do these mice are lazy. So within a few months, you can tell right away. Oh, by the way, I bought my staff a $50,000 digitized gait tracking system, and this is how they repay me. This is what they use. They use like glove boxes and paper gait tracking. This is how it's just faster and it works just as well. But normally a mouse, you just like tap it up the butt, it's gonna run through the maze, right? These mice, they just don't do that. They don't want to exercise, especially on a high cholesterol diet. And you'll see these mice now are going to be out of commission for 1 hour. They're completely exhausted. You can see it breathe. It's going to come back. It takes about an hour. But these mice just cannot exercise. And when you do histology on those mice, The ubiquitously mild model of MDX, Duchenne muscular dystrophy, that's for other labs. We got humanized models of muscular dystrophy, including the big kahuna DMD or Duchenne MD mice. So basically, you can see at 5 months, a bit of fibrosis. You increase cholesterol content in the diet, more fibrosis, and you can see like atrophy of the muscle. And then at 9 months, this is when they kind of kick the bucket. We have to euthanize them because there's simply no more muscle left. These mice are emancipated like you have no idea. And then when we basically look at cholesterol metabolism or cholesterol accumulation in those mice, these muscles are full of free cholesterol. This is Philippine stain, which stands for free cholesterol. This is like a 250-fold increase in myofiber free cholesterol accumulation. And if you use a double knockout, you then literally see rivers of free cholesterol in the tissue of those mice. This is laminin staining. You can see like all those like dying myofibers that are like literally collapsing in cholesterol. And now we basically came up with a pretty unexpected hypothesis. Is muscular dystrophy a cholesterol handling disease? That's why these mice are so sensitive to ApoE knockout or increased cholesterol levels. How can we improve muscular dystrophy patient care? Well, the first thing we did was to start to treat those mice with ezetimibe. Ezetimibe is an intestinal cholesterol absorption blocker. It blocks cholesterol absorption and reabsorption in the gut. It's not a statin. Statins are pleiotropic. They have anti-inflammatory effect. Now, we didn't want anything pleiotropic. We stick with something that is very specific, ezetimibe. And as you can tell, those mice do much, much better on ezetimibe. In fact, they're good forever. If you give them ezetimibe, they're good for years. Which suggests basically that cholesterol metabolism, cholesterol is what drives the disease, not triglycerides, just cholesterol. It really points a finger towards cholesterol. But it gets even more interesting than this. When we started preparing for a clinical trial, we start to look at cholesterol levels in patients. All those Duchenne Becker patients, they're all dyslipidemic. They all have high triglycerides, circulating triglycerides and high cholesterol. So if we basically look at total cholesterol abnormal values, LDL, this is bad cholesterol, triglycerides, and HDL, the prevalence of dyslipidemia in this population is 100%. They all have at least one abnormal cholesterol value. But there are confounders. These patients are in a wheelchair, and they're also medicated. So what we did is that we look at the gold standard model of muscular dystrophy, the Duchenne dog model of canine model of muscular dystrophy. They're unmedicated. They all have high cholesterol. They have high HDL cholesterol as well. They have high total cholesterol. And it's an X-linked disease, so females can miss one chromosome and being unaffected. We could call them carrier females. They don't have muscular dystrophy. They don't have high CK. This is the main marker for cholesterol, muscle damage. But look at this. They have high LDL cholesterol. If you miss one allele, you're going to impact cholesterol homeostasis. What does this mean? We think that Duchenne MD is a new type of genetic dyslipidemia. They're all dyslipidemic. And you'll see it is not secondary to muscle wasting. Why? Because those carrier females with no CK and no muscle damage, they're dyslipidemic too. We went back to our LGMD2B project. We have like samples from those patients. They have abnormally low HDL. So another type of muscular dystrophy that has nothing to do with Duchenne. They have low HDL, statistically significant. And we're publishing another study that reproduces these data. And it allowed us to basically state that muscular dystrophy is in fact a new class of genetic dyslipidemias. The prevalence of dyslipidemia in MD patients is incredibly high. And we've just published a few months ago, like a systematic review, like showing all dyslipidemic parameters and what's published in the literature. And when it comes to patient impact, yes, we published early on ezetimibe. We think there might be some grounds into treating patients with ezetimibe, but also simvastatin. But we'll get back to this later. Now at Children's, every kid diagnosed or suspected of a neuromuscular disease, gets a full lipid panel every 6 months. That includes muscular dystrophy, but also ALS, amyotrophic lateral sclerosis, SMA, spinal muscular atrophy. They're all dyslipidemic. The prevalence of dyslipidemia in that population is really, really high. Now we're basically trying to get funding for a final preclinical study of ezetimibe, which is the gut cholesterol absorption blocker that reduces circulating cholesterol, versus simvastatin. Simvastatin, which is a statin, might actually be beneficial in this case by blocking the muscle-free cholesterol accumulation we noticed earlier. But I said to you, like I would try to keep like things simple and accessible. Why so many cholesterol abnormalities in muscular dystrophy? What is the big link between cholesterol and muscular dystrophy? We think that there's no better way to kill a myofiber or to sabotage a muscle than by sabotaging its ability to regulate cholesterol. And why we say this? This is why statins cause myopathies. Statins are well known to increase CK level in non-MD patients, like in the cardiology clinic, for instance. Statins cause muscle pain, they cause myalgia, they cause in non-MD patients, like in cardiovascular disease patients. They raise CK. Rare cases of rhabdomyolysis. This is very, very rare. There's like 3 or 4 cases in Canada per year of severe rhabdomyolysis. But statins do the same thing as muscular dystrophy. They sabotage cholesterol homeostasis in the muscle, and this is how you sabotage a muscle. Why? Because muscles have a massive ability to regenerate. But one thing that they cannot deal with is interfering with their ability to regulate cholesterol homeostasis. Current and future projects. With Kate Selby at Children's, we're looking at dyslipidemia in pre-Duchenne patients. They're not even diagnosed. They're just at the NMD clinic for something. Something's wrong with them. We don't know what. They're not diagnosed yet. I think the prevalence of dyslipidemia is like 90%, even before they get diagnosed. That's how we found basically the first metabolic comorbidity of muscular dystrophy or Duchenne muscular dystrophy, dyslipidemia. Very high prevalence of dyslipidemia before diagnosis. And now we're basically, we got like the HMG-CoA reductase gene flux allele mouse to try to basically flux HMG-CoA reductase in the muscle to try to prevent complications and muscle wasting that's associated with muscle disease. What's really, really interesting, very last slide before we conclude, these mice that I showed you earlier, those mice that stop walking, like for instance, this mouse right here, if you give that mouse that stops walking, you give it ezetimibe, it's going to walk again. It takes a couple of months, but this is, for instance, the gastrocnemius of those double knockouts. After 5 months of treatment with ezetimibe, the muscle grows back. This is the tricep. This is like, these mice are good. Even if they're symptomatic, if you start treating them, they get better, stay better. So now we're doing spatial transcriptomic analysis of muscle lesions, trying to understand how can the muscle regenerate to such an extent? I told you the muscle has a massive ability to regenerate. It seems all to be controlled by cholesterol. And again, it explains why statins cause myopathies. They cause muscle damage, just like muscular dystrophy, and they interfere with the ability of the muscle to regenerate. So now going back to our first slide, I think I showed really good evidence that the endothelium, what goes on in those cholesterol-rich membrane microdomains, is really important, not only for vascular disease like aortopathies and even atherosclerosis, but also for what happens in the subendothelial tissues, like for instance, in the muscle. These caveolae lipid rafts, they're full of signaling molecules. They're also full of surprises. And if there's one thing I can say to all those you guys, your trainees present in the room or online, just follow your data. Because sometimes you never know what's going to be at the end of the tunnel. Hopefully it's going to be a light, not something else. But follow your data because again, if you do good experiments, something good is bound to come up from your work. This would not have been possible without a huge group of collaborators at Children's, at St. Paul's, in the lab, especially on campus. A big shout out to Fabio Rossi, Robert Nabi for example, on caveolae biochemistry of caveolae, and also Gordon Francis at St. Paul's, Kate Selby, our pediatric neurologist, and also Dina Panagotopoulos, who's Gordon and Dina are pediatric and adult endocrinologists, and they make sure that whatever we claim when it comes to cholesterol and dyslipidemia in this very unique population is kosher. So a huge thank you for to these people, and also a huge thank you to you guys for your attention. Happy to take any questions you guys may have. Thank you.
Oh, never mind. Students first. Peter.
I like that.
Is this on? Great talk. That was
Thank you.
really interesting. Two questions. First, about the temlesartan. I don't know if I'm saying that right, but have you ever looked at if it just upregulates enos in
It
cells?
does upregulate enos.
Yeah.
The problem is that, well, we're developing mice that don't have any angiotensin receptor. How can mice that don't have the receptor of the drug upregulate enos? There must be another receptor out there. What exactly it is, we know it's related to the caveolae system, but what that actual, like the molecular target of those molecules, we don't know.
Okay. And my other question is about the cholesterol regulation story. Have you looked or maybe think about looking in the liver and see if there's any effects on the LDL cholesterol uptake or any of that?
You're bringing back painful memories. When we started looking at dyslipidemia in patients and in mice, we said, oh, it's the liver. Like, you're really right. I mean, it should be the liver. And we looked at the liver and we proposed a CIHR, liver, and to a muscle panel, knowing that the muscle panel would not be interested in liver biology. And we found some minor differences. But what really got us going again with free cholesterol was when we started looking at the muscle free cholesterol. We think that it's a new type of dyslipidemia. Like an endocrinologist will see a lipid panel from those patients. This is not normal. I mean, it's dyslipidemic, but it's not cardiovascular disease dyslipidemic. It's something else. We think that it is the muscle itself that synthesizes cholesterol. And cholesterol crosses the sarcolemma, gets into the vasculature, crosses the endothelium, and affects lipid parameters. It's not liver that causes dyslipidemia. It's the muscle that causes dyslipidemia. And whatever changes in the liver, it's compensatory. It's not major. But what happens in the muscle, holy shizzle, that's another kettle of fish. The muscle are really messed up. They're full of free cholesterol. And HMG CoA reductase is up, actually.
Yeah, great talk, Pascal, for both parts. So I have a question for the morphin side. So morphin essentially is a fibrillin deficiency, right?
Correct.
So fibrillin is made by fibroblasts. So how is now the connection, and it stabilizes suppose elastin fibers. So how is your connection to the endothelial cells into the NO system? Kind of, they are not officially directly connected. So how do they come together?
That's a really good question. When we look at our transcriptomic analysis of NO with Ribitol or drugs, we didn't find anything related to, actually, that's not true. We got an increase in collagen. That might be a fibroblast-mediated compensation. We saw a lot of contractile machinery of protein upregulation with telmisartan in an NO-specific fashion, which might be due to smooth muscle cell signaling. What we think with the morphin-enos, the gigantic hierarchy that they have, is that NO buffers everything that's going on in the subendothelial tissues. It just keeps everything quiescent. And if you sabotage enos, the smooth muscle cell and the fibroblast will kick into high gears. And then this is when you sabotage the aorta. That would explain why patients have endothelial dysfunction, why enos knockouts is far worse in the context of morphin, and why those ARB, those like telmisartan, have anti-atrial root widening effects, is gone in enos knockouts. It's an NO disease. It's an endotheliopathy. But again, we're preaching for our own church. So maybe it should be more complex than this. But everything we do when it comes to NO, everything pans out. Okay, did I answer your question?
Yeah. Maybe a little extra for the cholesterol part. So my brother, for instance, so he got statin prescribed and this cholesterol uptake inhibitor. My brother got statins.
Oh, statins, yeah.
And this, forgot the name, this cholesterol uptake inhibitor, right? So isn't it contradictory to give both drugs at the same time?
No, they're synergistic. So basically,
essentially you ruin your muscles at the same time, you maybe recover it, but this uptake inhibitor has a very strong effect on your stomach, right? So did you look any problems in the stomach area of your mice?
We did not, but that's why when we published our study 2 years ago in GCSM, We have ezetimibe, which affects the gut, but we also have cholesterol. We basically did two studies. We increased cholesterol in the diet, which makes the disease worse. And when we give ezetimibe, it makes the disease better. So we have two completely different approach to dissect the same, that suggests the same thing, that it's a cholesterol thing, but we didn't look in the stomach or the gut to see whether those drugs cause intestinal toxicity. Ezetimibe is actually, they did some toxicology study in dogs, and the dose that they give to dogs for toxicology studies is through the roof, and there's no toxicity. It's just a drug that stays in the gut and is just not absorbed. It just stays there and it doesn't do anything. It's surprising. Those two drugs are very surprising because they could not be any different from their mechanism of action and their location. One gets absorbed, goes straight to the liver, sometimes gets to the muscle and causes issues, at least in non-MD settings. But ezetimibe just stays in the guts, and you can give them gallons of ezetimibe. It just stays in the gut. There's no toxicity with ezetimibe. To my knowledge, ezetimibe is as safe as it gets. Actually, you know what? That's the thing. I mean, it's a bit like statin. Some patients are statin intolerant. You give them the minimal dose of statins, and they say they've been running a marathon. There's some drug heterogeneity out there. That's interesting.
So when they were developing the drugs, the losartan versus the telmisartan, so in theory they thought they were hitting the same receptor because they had a similar effect, but actually they're hitting parallel targets probably then, right?
They what?
Hitting parallel targets that are in the same pathway that are having a.
It's a bit more complex than this, unfortunately, but we don't have a lot of time.
Well, does the telmisartan still bind to the
AT1 receptor?
Yeah.
Oh, they both block the AT1 receptor, but we think that they have another.
That's off-target effect, yeah.
It's an off-target effect, but it's more complex than this because there's a couple of binding sites. So all those ARBs are derived from angiotensin 2, amino acid 1 to 5. So basically, they're derived from a peptide, an endogenous peptide, and we think that peptide has other activity. There's another receptor. On the AT1 receptor, those ARBs can behave as biased agonists. They have another binding site. And they also are known to work as inverse agonists, which is to stimulate. They can behave like an agonist. It's very complex, but they do other things on the receptor than blocking angiotensin 2. Now the question is, all those pleiotropic effects we see, is it through AT1 pleiotropism or a new receptor?
Did you check the renin pathway?
We did not. We did some things in the kidney, but we didn't look at the renin pathway.
I mean, to telmisartan effects, no.
I see no more hands up. Pascal, thank you so much for a great talk. Very insightful and provocative.
Jason White. That's the Jason who participated in my lab.
Yeah.
Yeah, that was the one that paper.
Which paper?
The one you showed up here at the end here, the Marston's there.